Douglas Huber with Christian Connections for International Health. And as CCIH has recently taken up the role of advocacy, and I was on the board when we decided that this was a part of our work, which we interpret as evidence-based public education at the grassroots, but also for our colleagues on the Hill. And having been warmly welcomed in congressional offices, we thank the staff who have done that. And we've also been pleased that our colleagues from the Global South, who we've brought with us, have also been astonished at the welcome. But I'd like to invite the panelists, and particularly Shellie, to give us some guidance, a little bit more, and comment as to what seems to work well for congressional offices, and perhaps, if you wish, some of those things which didn't work so well.
I could go on all day on that one. And I've seen it all. Never make threats. That's the one issue I will always tell you. Oh, sorry. I never make threats. I have two 11-year-old boys. I don't take my own advice. I threaten all the time. But in terms of a staff, I'm not going to be your friend. I'm not going to be your advocate. I'm not going to want to see you next year if I'm worried about things worried that the meeting's not going to go well. So be positive. There are going to be people that are going to agree to disagree, but sometimes those folks can be won over. Don't go in with the assumption of they don't quite get it. It just takes one staff member that you can educate and bring to your side by giving facts, by bringing it back home, knowing back in the community, do a little research of what religious leaders the member of Congress may be close to, what are the big churches who are involved in global health, invoke some of their names, just make it local, because unfortunately most of these members have never been to a developing country or have been to see exactly what type of program your missionaries are doing, especially in the healthcare field. They may know that somebody's going over there to build a church, but they don't understand as part of that church is also a nutrition center. Let them know exactly what the money their constituents are raising or going for, and the differences in the communities that make to go forward. And don't be discouraged. You're going to find people that are just not nice or not educated, or don't think we're all like that. and you're going to have people from all different backgrounds, too, that maybe just have no understanding. And I have to admit, I was one of those before I started working on welfare reform, exactly what the faith-based communities had to do with local and international government programs. You know, just what I can say in the next couple of days, Google the communities that you're going to visit, you know, the members, and find out who's doing what in those communities, because really, all politics is local.
Someone? Yeah. Larry Kazazet with ACAM, African Communities Against Malaria. And I spent a lot of time, particularly in East Africa, and there was a point where when I was out there, I was quite reluctant to tell people I was an American. I was a Canadian. But today, that is no longer the situation, because I have taken my own tour of PEPFAR facilities and seen the superb quality of counseling and interpersonal connections between staff, which means somebody's been trained very, very well. Plus the supplies. There's no question there's going to be continuity of supplies there. I just am so blessed to see that as an American. And I'm wondering now, when is it, in terms of the overall policy, that we're beginning to start to look beyond treatment focus services and look more toward prevention, education, because there's a huge onslaught of the populations, young people, particularly Africans, who we don't want to have to seek out a PEPFAR supportive facility to get treatment with ACT. So who's calling the scheme here, the design, the proportion of budgeting that's going to strike a balance between prevention and treatment?
Okay, thanks, Larry. So I guess the basic answer to your question is, it is the countries that are really in the leading role, and that we want to be in the leading role. So to the extent they're not yet rising to that, we're trying to move them there. All these countries have national aid strategies, and our goal is to be supporting their strategies and to have them in the role of saying, okay, PEPFAR, we need you to focus on this. We need you to focus on technical assistance for this kind of activity, or we need you to focus on strengthening our supply chain here, there. And the picture varies from country to country. But we would like to get away from the initial situation with PEPFAR, where we were kind of going in and doing our thing based on our best understanding of what the needs were, and get to one where we're doing what the country, meaning the government, but the government in consultation with the FBOs and civil society and people living with HIV/AIDS, what they think is needed. PEPFAR has definitely supported the whole range from prevention to treatment. Treatment definitely gets the most attention, and we now know that treatment is a form of prevention. So one positive development from that really is to kind of put the prevention versus treatment dichotomy behind us a little bit and say, okay, it's all a unified whole with many different elements. So I do think when we talk about prevention, we mean treatment, but we mean the biomedical interventions such as male circumcision, mother-to-child transmission. But there's always going to be a role for behavioral activities. There's always going to be a role for focus on youth populations in particular. Last thing I'll say is I think faith-based organizations have already been important in that piece, but they've been important in the whole range. They really have. Catholic Relief Services is here today, and they've been one of our largest treatment implementers, and now have been part of this transition where they've been handing over control to local organizations in the countries, but remaining in a very critical technical assistance and support role. So FBOs have been part of the treatment activities, certainly part of counseling and testing. Something we haven't mentioned is orphans and vulnerable children. I mean, PEPFAR is really one of the world's largest orphans and vulnerable children activities. And FBOs have been important to that. So I would say we want to support the countries, but we want to make sure they're addressing the whole range of needs. And we will try to make sure that FBOs are there for all of it.
Thank you very much. I'm just wondering, when it comes to sexual and reproductive health for women, how much are the members influenced by the faith community in their decision making in that? And how are you interacting with the State Department, USAID, with all the proclamation and executive orders that have been given on sexual and reproductive health, women's empowerment, human rights, and other things like that? Thank you.
This is a tough one, because this is the one area that so many members look at their own faiths, look at their own beliefs personally on their views of reproductive health. There's not policy issues that drive them. This usually is a very personal decision for them. In terms of the decisions on State Department and USAID's programs, the big questions we've been asking: are you making programs choose between reproductive health programs and supplying traditional PEPFAR and malaria programs? Are you making a choice? And this is very broad, but this is part of the discussion. Are you choosing between birth control and IUDs and ARTs and anti-malarial drugs? And we never want a country to have to make those decisions. And right now, that's the big sticky point. Unfortunately, there's not enough money to go around for everything. But what we're trying to do is through efficiencies in the program, and the AIDS office, PEPFAR office, has been very progressive about how to cut and make the programs more efficient to free up some money for these types of programs. But in terms of overall comprehensive strategies, this is just a very tough role right now, because everyone has an opinion on how the U.S. government should take a role in reproductive health. Something to add?
No, only to say that it's a balance for USAID, both in supporting different faith-based organizations. Sometimes those issues come to the fore, and we have been able to work things out so there's clarity, and so that we can support those who may have some objections, at the same time engage the fact that you have a lot to deliver on the front. And on the Hill, being new to government, I have to say that there's a great intelligence in democracy on the Hill. I mean, all of the recommendations, you can see the various beliefs coming together and finding the very tight, narrow middle ground that still allow us to move forward, and we will continue to. In the 2013 proposal of the budget is the one area that has grown is indeed in family planning. And we all know that delaying the age of first birth, space in birth, are very important for everything we do in health. And there is a sense that the world is getting to a stage where that is getting more traction. Africa, many countries in Africa are still to get there, and it's going to be important for the future health and economic development of the continent.
And one other point, something that we're seeing, countries that have made huge progress in reproductive health, whether it be in encouraging women to wait before having their first child, birth spacing, issues like that, have become from the leadership of the country, whether it's the head of state, the president's wife, or female head of state, the minister of health, because in the countries where this isn't a priority from the head of state or someone senior in government, there's a lot of reluctance in the states, in the provinces, in the country on a whole, to adopt family planning programs.
Thank you all very much. And please, again, thank the panel here, and thank you for your attention.